A very good day, my dear postgraduate students. The topic that I had chosen for today is again from a recent advance, but it is from a recent advance, 25, having the university exam in mind. Metastatic solid tumors of the testis by Ivan Damjanov. This is one of my references which I have shown in the inset. The topic by itself is simple and dangerous. In the sense, it is more analytical. Look at these words. The findings are incidental, more of a retrospective study. What is the epidemiology? How common is it? What is the study design? Etc. Looks like more of a thesis presentation on one side. On the other side is the list of the common tumors involved in the metastasis, the IHC, and of course the references at each level. So this is somewhat difficult for us to handle in the sense it is somewhat off track from the routine pathology. Definition of a solid tumor. It is an abnormal mass of tissue that does not contain cysts or liquid areas. The solid tumors may be benign or malignant, carcinoma or sarcoma, and even lymphoma. However, the recent advance 25 itself mentions lymphoma as a separate one, and hence it has been avoided in this. Not that you people should avoid it in your exam. I shall be dealing with it in a different class. Leukemic infiltrate have been exempted, though the leukemic infiltrate into a solid organ is controversial, it has been avoided. Coming to the introduction. All of us know that the common organs of metastasis are lung, liver, bone. We have got the brain, of course, which is commonly involved, and one of the most common adrenal endocrine organs is the adrenal. Otherwise, the testis and endocrine are relatively rare in metastasis. Therefore, the topic assumes its importance. They have been obtained from the surgical specimens, the FNAC, or the autopsy. It is a problem to both the pathologist and the oncologist. Imagine a glandular malignancy in the testis and calling it a metastasis, and then the primary is not known. It is quite a challenge. Look at the incidence, it is quite low. Thyroidectomies, 9 out of 5,000. Less than 1% of all thyroid malignancies. And the results are variable in a population. Parathyroid, islet cell of Langerhans, etc. are unlikely to be involved. Adrenal, however, has got more metastasis because of its copious blood supply. The adrenal in this study is shown as the fourth common tumor after the lung, liver, and bone. The data from the terminally ill patients has been avoided because the patient is already flooded with malignancy all over the body. The metastatic solid tumors of the testis are usually rare and unilateral. There can be some overlapping features of the paratesticular tumors, such as tumors of the R.A.T.S testis, a slide for you, epididymis, mesothelial tumors, and sartorial tumors. Prostate is the predominant source of the primary and accounts for nearly 50% of the cases. The others being colorectal and renal cell carcinoma. Scrotal malignancy by itself is quite rare because of the low temperature. What is the physics and the biology behind it is not very clear. Look at this one. It is a study from this particular reference. And the test is it is showing an ill-defined mass, a nodule over here. It is a case of a malignancy that has been discovered a decade later, the original being from the prostate. And this itself is a method of study, the radiofrequency ablation. So we shall mention it, and we will also mention that it is quite rare. Sometimes even after the treatment of the primary, it could be found. We have mentioned all these. The lymphoma has been avoided in this particular presentation. The incidence is usually 1 to 2.5%. On an average, it is about 1% of all testicular neoplasms. The patients are older and beyond 57 years of age. In fact, compared to the primary, the metastasis is supposed to be occurring in patients of older age. The sources of study in this particular report is from the case reports, short series, and review of literature, and maybe occasionally autopsy, which has been included in the review of literature. The common primary tumors are prostate, and Anderson, it differs. It is one center where the study has been conducted. The disadvantage of this particular study is the number of cases for study is small, and there is no systematic hospital or population data, which is standardized. In carcinoma prostate, multiple organs can be involved. Testicular metastasis, as I mentioned earlier, may be about 1% of the case. Orchidectomy specimens are usually done for therapeutic purposes in a case of CA prostate. Again, we do find a malignancy in the testis, as I had shown you earlier. It can be a synchronous or a metachronous neoplasm. It can be unilateral. Mostly it is unilateral, and very, very rarely bilateral. This is an important table as far as this presentation is concerned. And it deals with the various authors over here and the centers where the study has been conducted. What is the mode of the material and the number they had chosen? For example, in this case, nearly about 24,000 autopsy records have been studied. And what is the source of the primary tumor? So it ranges from prostate, renal, adrenal, melanoma, lung, etc. It varies from center to center. One look at it, I find that it is not uniform throughout. And in different parts of the world, it is different, maybe because of the different statistical registrations. The common list of organs you people can remove. Coming to the routes of spread of tumor to the testis. So a couple of schematic diagrammatic pictures. So there is a reference over here. I find that there is a bladder, there is a colon and the rectum, the penis, the testis low down, and this is the prostate. Also, have a look at these pictures. There is a convoluted ductus deferens ending up in the epididymis, the testis is low down. Prostate, the bladder, the seminal vesicle. The authors say, strangely, the bladder is rarely involved as a metastasis in the testis. The routes of spread can be either direct from the urethra or the scrotum, or two, there can be a retrograde spread from the lymphatics and the venous. Also, there can be an endocanalicular spread via the seminiferous tubules. Lymphovascular have been mentioned. So, please have this roots of spread in mind, which is not very easy to understand because testis is somewhere low down and the rest of the organ. You will be only thinking of the proximal spread along the para-aortic and upwards. But in this case, most of it is retrograde. The metastasis from the prostate have been studied by gallium-68 PSA positron. It is an emission tomography. It can be used for micrometastasis. And there is a destruction or interstitial fibrosis that is involved. Prostate-specific antigen can be used for confirmation. Grossly, sometimes we can see visible nodules, as I had shown you in one of the first pictures. And usually the tumors are grade 4 or 5 Gleason. Nodules are large in the Wang study, yellowish white, tan, or firm to fleshy. And basically they are of the ductal type, radially arranged with prominent nucleoli. In the prostate, again to confirm, a couple of IHC markers have been done. NKX31, it is a recent amino acid protein expressed by the prostate that has been used in the diagnosis. Look at the extent of positivity in a prostate. I had superimposed these. Not all of them are really metastases, but for a prostatic malignancy to be confirmed, it is definitely useful. Also, there is the ERG expression, which is strong, whereas the P10 loss is minimal. Next comes the lung cancer. It is one of the most common cancers, common metastasis being the other organs, lung, liver, bone. To the testis, it is quite rare and it can form a solid metastasis. All forms of tumors, including the squamous cell carcinoma, adenocarcinoma, and the small cell carcinoma, have been implicated. Very occasionally, neuroendocrine malignancy has been noted. Rarely symptomatic before the primary, and this is the age of the patient. The secret to success is constancy in purpose. The next group will be the gastrointestinal malignancies. These are the common organs of metastasis anywhere in the GAT itself. And you find that because of the lymphatic invasion, the surgical specimen, and the involvement of the testicular artery or vein, there can be a peritoneal dissemination, including involvement of the testis. So these are okay. But the main problem is it mimics the hydrocele of the testis. There can be the mesothelium along which they are all spreading, and then there is a secretion leading to a picture of hydrocele or an epididymal cyst. It can be masquerading or misleading. And again, the routes of spread are either the arterial blood flow, the retrograde venous flow, the vas deferens, or the tunica vaginalis. This incidentally is, again, look at the signet ring cells which are seen over here, the arrow marks over it. And the testicular swelling has an initial presentation of a tumor with the gastrointestinal tract, the metastasis. This is the reference. Metastatic signet ring cell adenocarcinoma of the testis. So, this is a glandular tumor that comes under the entity of solid tumor, which you people will have to mention in your answer. Next will be the colorectal carcinoma. Now look at this one. So, there is a malignancy with a large cystic space, in spite of which it is being called as a solid tumor. Pancreatic carcinoma is the next one. The endocrine is not commonly implicated, but then you find that the pancreatic solid or the pseudopapillary tumor has been found in 1 or 2 cases. And there can be a paratesticular or a scrotal metastasis. The routes of metastasis to the testis will be either by direct invasion, retrograde, lymphatic, transperitoneal seeding, and a congenital hydrosis. These are all the things by which it can be involved. From the liver, it can be a hepatocellular or a cholangiocarcinoma. It is aggressive, but testicular metastasis in isolation is rare. It can be reported in cryptorchid testis. Renal carcinoma is relatively more common and it occurs to the regional lymph nodes and renals. Testis is very uncommon, and these are the authors who found it in 1946. And look at the rarity of this lesion. Ipsilateral is more common, rarely it can be bilateral, and it is usually solitary. There is a lag period of 2 to 3 or even 6 years, 2 months to 6 years. Metastasis commonly presenting is a clear cell renal cell carcinoma. Periaortic retrograde spread, spermatic vein is again implicated. The presentation can be, the tumors can be having either individual infiltration as we are seeing in this, or they can be having broad pushing margins as in this picture. And most of the tumors, as I had mentioned, they are hollow tubules made up of clear cells, and sometimes there can be cystic spaces. Vascular invasion can be seen. PAX8 is a marker, and CA9, carboxy anhydrous, are positive in a case of renal cell carcinoma. And there is a case of a bilateral testicular tumor metastatic from the prostate. This is a reference over here. And look at this. All the credit goes to this particular author. I had taken it just to show the metastasis to the testis. Sometimes you find that they are all poorly differentiated, also looking like blastemal cells. So they are all mimicking the seminoma or poorly differentiated malignancies. Look at this insert, it mimics almost a seminoma. That kind of a picture can be seen from the prostate. Again, the routes of spread we shall be remembering and recollecting. From the bladder, it is rare. From the prostate, it is common. It can be either by the ductus deferens, or it can be from the seminal vesicle as such. Also, the retrograde lymphatic spread is there. And when I say lymphatic, you find that the drainage is going to be above. But then when there is going to be a block, there can be a turn and then a retrograde spread, by which it comes back to the testis. So also a retrograde vascular spread. So there is a group of lymph nodes, the normal lymphatic drainage of that particular region that I had shown. And this will be the structures that we will have to remove. The urology report, just see over here. It is a testicular malignancy of the cancer of the colon. Nobody believes it. Probably I could see a testis over here, but then it is being pushed by means of a tumor. And on cutting open, there is a nodular lesion. Multiple bits have been given, wherein there is an infiltrating adenocarcinoma that is involved, and these are probably atrophic tubules that are seen from urology, and this is the report. The squamous cell carcinoma. Usually it occurs in the region of the scrotum, and there can be the urethra also that is involved. Look at this one. It is almost being replaced. So the mode of spread can be either by direct contiguity, or from the urethra, or from the scrotal skin. Distal squamous cell carcinoma is unlikely. Other rare tumors are, one is melanoma, and then in such a case there can be ejaculated sperm which is dark brown or black in color. And melanoma can also metastasize to the ovary. And again, this is more common than the testicular metastasis. Bladder, as I had mentioned earlier, it's quite uncommon. Merkel's carcinoma is also rare. Neuroblastoma is again very rare. So the common tumors that you people can mention can be, one is the prostate, 2 will be the pancreas, 3 will be the gastrointestinal tract, 4 can be the lung. and 5, the kidney. These are all the key points. One is the metastasis, which is quite rare. It is found in a case of widespread tumors. Sometimes it can be a solitary nodule. Age of the patient is this. Most metastases are adenocarcinoma and scrotal neoplasm, Mullerian adenocarcinoma, mesothelioma, we should be having in mind. GIT tumors can be involving the more peripheral regions such as the epididymis. What are all the differentials that should be there? The treatment can be a radical orchidectomy. It is not a cure for itself because it is a metastasis, but to alleviate the pain. There should be adjuvant therapy based on the primary tumor. The prognosis per se is quite good. And this will be the reference for it. I had given it for the sake of completion so that in case it is asked as a question for you people from the recent advance, you should be able to answer. Now that it has been asked in 25, there is a high chance that we might get this as a question. In the middle of difficulty lies the opportunity. Thank you.